Okay, right. So we are almost done. Today we will go through the rheumatology questions. Hi. Now, yes. So the first question is on osteoarthritis. Okay. Now, osteoarthritis is a very, very common rheumatological problem. And as with most rheumatological diseases, it's commoner in females, right? And also we are able to clinically phenotype osteoarthritis into generalized nodal osteoarthritis, hip osteoarthritis, and knee osteoarthritis. Right. Right. So the first question is, true or false regarding osteoarthritis? Right. Is more common in males kenika වැරදි, right? Right. Now, as I told you, you are able to clinically subtype the osteoarthritis into generalized nodal, knee, hip osteoarthritis, right? And in the nodal osteoarthritis, it's very common to find these nodes. And on the examination, you can easily detect these nodes. So Heberden's nodes occur in the distal interphalangeal joint, and Bouchard's nodes occur in the proximal interphalangeal joints. Now remember that nodal osteoarthritis has a familial association and typically causes sort of polyarticulous involvement of the small hand joints. But it can also cause increased frequency of osteoarthritis in the knee, hip, and spine as well. Right? So the Bouchard's nodes, again, MEVA, are in the proximal interphalangeal joint, not in the DIP. DIP is Heberden's nodes. Right. Okay. Osteoarthritis, joint deformities are rare කියන එක වැරදි, right? Obviously, there can be joint deformities, as you can see. You can see the joint deformities here, right? Even in the knee, when this occurs, you get this knock knees, genu varus, genu valgus deformities. So, are rare කියන එක වැරදි. You see quite a lot of people who have joint deformities in osteoarthritis as well. Nodal osteoarthritis, Mankiwa, is associated with knee, hip, and spine osteoarthritis. There is an increased frequency or prevalence of osteoarthritis in other areas in the nodal group. Right. Now, when it comes to knee and hip osteoarthritis, as you can see the very typical X-ray changes of osteoarthritis in these radiographs, right? So essentially what happens is, there are a few changes that happen in the X-rays. One is there is loss of joint space, right? So the joint space loss causes the bones, ends of the bones to rub against each other, causing periarticular osteosclerosis, right? So it's osteosclerosis around the tips of the bones, edges of the bones. In addition to this, you get osteophytes, right? So for example, these bony sort of prominences that you see are osteophytes. And also you see sort of subchondral cyst formation as well. So in these places, you can see cyst formation, subchondral cyst formation. Usually in the knee, it is the medial compartment that is affected, and in the hip, it is the superior compartment of the joint space that is commonly affected. So knee osteoarthritis usually affects the lateral compartment, medial compartment very poor affect. So it is the medial compartment that is affected mostly. Hi. Okay. Any questions about these ones? Right. So question number 2, further discussions on osteoarthritis. Subchondral bone cysts are seen on radiography. Yes. So the key changes I have explained are the loss of joint space, the sclerosis, the subchondral bone cysts, and also the osteophytes. So these are new spurs of new bone formation are called osteophytes. Right? Now, in osteoarthritis, even though traditionally we describe this as a subchondral cyst, right? And you see the osteophyte there, nice. Right. Now, even though we described osteoarthritis as a non-inflammatory disorder, right? That's the traditional thinking of osteoarthritis. Now we recognize, no, there is a bit of inflammation going on in osteoarthritis as well. So this is sort of, people started thinking about it, because even in very pure osteoarthritis, CRP might be slightly high. Also, if you take a joint fluid aspirate, there are not a lot of cells, but there are neutrophils in it, and neutrophils are the predominant cell in that joint fluid. Godak නෑ obviously septic arthritis තරමටම neutrophil නැහැ, but most of the cells are neutrophils, and there are few cells there. So there is an element of inflammation that is going on, and that has opened up an avenue of research into sort of inflammation-based research in osteoarthritis. So CRP is slightly high. Obviously not as high as rheumatoid arthritis or infection, but it is slightly high, right? And also you can get a few cells, predominantly neutrophils, in the joint fluid. And how do you treat osteoarthritis? Unfortunately, the treatment of osteoarthritis is not very easy. It's just, we don't have a lot of options. Analgesia with analgesics, of course, and sometimes intra-articular steroids are useful, right? You'd have seen these being done in the wards. Intra-articular injections of steroids can be useful again, building on that theory of inflammation. There's a little bit of inflammation in osteoarthritis. And of course, patients who have very severe osteoarthritis will need joint replacement, right? Joint replacement avashya වෙනවා. So arthroplasty in severe osteoarthritis, usually deforming, very severe osteoarthritis, people can't even walk or mobilize. These sort of patients will need joint replacement. Intra-articular steroid is a contraindicated කියන එක බොරු කතාවක් that is used in the management. Okay. Any questions about this one? Question number 2. ප්‍රශ්න මොනවාරි තියෙනවද? Satya, do you want to ask a question? Mic is switched on. No?
Sorry.
Okay. That's okay. Hi. Okay. Next we move on to rheumatoid arthritis. So the next few questions are on rheumatoid arthritis. Now we've talked about this as a long case. For most of the groups, I discussed the diagnosis and management of rheumatoid arthritis. Right. True or false regarding rheumatoid arthritis, HLA-DR4 is associated. So HLA-DR4 අමතරව you can get association with the HLA-DRB1 as well. Hari? So take a hari. Now rheumatoid arthritis typically presents with long case bilateral symmetrical, right, inflammatory type polyarthritis. So bilateral symmetrical inflammatory type polyarthritis, commonly involving the hand joints. So you should know this. Metacarpophalangeal and proximal interphalangeal joints are the common affected joints. Metacarpophalangeal, proximal, interphalangeal. That's a common presentation. But remember, sometimes rheumatoid arthritis, especially in the early stages, can present with a migratory type arthritis as well. Migratory polyarthritis. Right? So that it can present with that. So especially in the early stages. Now, as I told you, the main involvement is the hand small joints, the proximal interphalangeal and the metacarpophalangeal. Right. Hip joint is almost never affected. Right. Spines are not commonly affected. Right. Except the possible exception to that is this atlantoaxial subluxation that can occur as a complication of rheumatoid arthritis. DIP involved in it. Rheumatoid arthritis, DIP is spared. Is involved. This is in contrast to osteoarthritis, which involves the DIP, and also psoriatic arthritis involves the distal interphalangeal joint. Over MCQ psoriatic arthritis and osteoarthritis involve the DIP, whereas rheumatoid arthritis will never involve the DIP. So these are just clinical patterns of the disease. Right? So hip almost never affected. Spine can be affected, but not very commonly. Commonly, Right. Any questions about this one, number 3? Now this I have just put up as, just go through these lists and sort of look at the extra articular manifestations of rheumatoid arthritis. Right? මේක විභාගයේ ලේසියෙන්ම true false එකක් දෙන්න පුළුවන් කම. Right? What of the following are extra articular manifestations of rheumatoid arthritis කියලා ලේසියෙන්ම දෙන්න පුළුවන්. Right? So yeah, and we have discussed some of these concepts in the long case as well. These are some of the ocular complications, like you can get corneal erosions, right? Ulceration, corneal erosions, right? Dangerous condition that is, and episcleritis. The so perforation of the sclera or scleromenageal perforance. Lung involvement is quite an important entity. So you have interstitial lung disease, right? You can get interstitial lung disease. Bronchiectasis is another mistake. So interstitial lung disease, bronchiectasis. Then you get rheumatoid nodules in the lung, right? And when exposed to cold, this can cause a very nasty disorder, right? Kaplan syndrome, CAPLAN. So that's rheumatoid nodule on top of cold worker's lung. Kaplan syndrome, right? Bronchiolitis obliterans is sort of an asthma-like small airways disorder that you get in rheumatoid arthritis, right? So interstitial lung disease, rheumatoid nodules in the lungs, bronchiectasis, Kaplan syndrome, right? And pleural effusions are all seen in rheumatoid arthritis. So ulcer skin manifestations, pyoderma gangrenosum, true, is right. And rheumatoid arthritis patients can manifest nephrotic syndrome, right, because of amyloidosis in the kidneys. So amyloidosis is correct as well. Right. Now I briefly described rheumatoid arthritis. So you get this atlantoaxial subluxation. Yes. So atlantoaxial subluxation, and you're very careful with these patients when you're giving them, when you're tubing them, you can cause cervical cord compression and quadriplegia. That is also true. All right. Okay. Tesura.
So in rheumatoid arthritis, although DIP is not involved, they get these deformities like swan neck and boutonniere.
Oh, that is because the tendon. So joint tendon tendon sort of sublux, and that is why they get those deformities, right?
Right. So
not a disease of the joint, but it is because of the other joints involvement and also the tendon structure you get those deformities.
Right. Okay.
Right. Okay. Right. Any questions with this one? Number 4. So you have to have an idea of these extra-articular manifestations. So here it's very difficult to say what the common ones are. It depends on where you do the study. Certain things might be common. Rheumatoid nodules in the skin are very common, right? Lung disease is common, right? And this is just going by my experience. Anemia is common. So there are certain ones that you see every day. But it's very difficult to put a number onto these. And depending on where in the world you work, you will get a different set of common complications, right? Right. Now, question number 5 focuses on the diagnosis of rheumatoid arthritis. And this is something that I am sure that I have shown you before. By most groups, I did a long case on rheumatoid arthritis. So we use the EULA or EULA/ACR criteria for diagnosing rheumatoid arthritis. And in that, you have 4 big domains. Joint involvement, where more marks are given for small joint involvement, right? Demonstration of serological positivity. And here you look at rheumatoid factor and anti-CCP. And then you have to demonstrate that there is elevation of acute phase reactants like ESR, CRP. And in order to make a diagnosis of rheumatoid arthritis, the symptom duration should be at least 6 weeks, right? So we use these points to diagnose rheumatoid arthritis. Anti-CCP is more specific and sensitive than rheumatoid factor, right? Whereas rheumatoid factor can be positive in people who don't have rheumatoid arthritis also. So a good example of this, somebody who has a family history of rheumatoid arthritis can have a positive rheumatoid factor, right? But anti-CCP is definitely more sensitive and more specific for rheumatoid arthritis. However, ඔය දෙකම ගොඩක් වැඩි නම් anti-CCP or rheumatoid factor positivity is a marker of poor prognosis. There are two things you can say. If you're anti-CCP or anti-rheumatoid factor in a rheumatoid arthritis patient is high, that can indicate, number one, poor prognosis. It can also say that the patient might have a higher probability of having extra articular disease, right? So high rheumatoid factor / anti-CCP will indicate poor prognosis, also higher probability of extra articular manifestations. ඔක්කොම MCQ වලට අහන දේවල්, අහලා තියෙන දේවල්. හරි. Okay. Now, then the X-ray changes. So මෙතන හරි. මේක මේ මෙතන මම similar කියලා කිව්වට මේකෙත් slightly higher. හරිද? Sensitivity එකත් slightly higher. Specificity definitely is higher. Okay. හරි. මේ ටික මම points ටික කිව්වා ඔයගොල්ලන්ට. Now, these are typical X-ray changes of rheumatoid arthritis. All of you have seen these things, right? මෙතන මම අහලා තියෙනවා joint erosion. The statement is not complete. Joint erosions are the earliest manifestations in the chest in the X-rays. At joint erosions, you get these slight widening of the joints. That is the first thing that you see on X-ray, right? Not the erosions itself, right? You get a slight widening of the joint space first, and then you get a bit of sclerosis around the joint space. Those are the two earliest manifestations. ඊට පස්සේ තමයි erosions end, right? So when you're investigating a patient with rheumatoid arthritis, obviously we've talked about the CCP, rheumatoid factor positivity. What does that mean? When you do an X-ray, the earliest changes are, one is slight widening of the joint space with bony sclerosis around the joints. Then you get the X-rays, the erosions. I think the earliest manifestation is erosions maybe. Right. Now, finally, say if you have an involved joint, especially sometimes you can have, joint sclerosis, osteopenia, what am I saying? So periarticular osteopenia, right? So by slight widening of the joint space with periarticular osteopenia, right? That is what, those are the earliest changes. Or periarticular osteopenia වලට කලින් තමයි joint widening එක. So actually, if you are very specific, the joint widening is the first feature. Then තමයි osteopenia. Sclerosis sorry, osteopenia. Right. Thank you for correcting that. Right. So anti-CCP rheumatoid factor positivity ඒව ගැන කතා කරා. Right. Now sometimes rheumatoid arthritis you can get a big monoarthritis. And ඒ වෙලාවට අපි සාමාන්‍යයෙන් we aspirate the joint. If you aspirate the joint, you might be able to observe lymphocytosis in the joint. Neutrophil තියෙනවා, lymphocyte තියෙනවා, right? But most of the time it is prominent lymphocytosis that you get, right? Pleural effusions complicating RA have low glucose levels. කියන එක හරි මම pleural effusion කරනකොට කියලා දුන්න දෙයක්. හරි. Right. This we have discussed. So rheumatoid factor anti-CCP. Rheumatoid factor is an IgM antibody. If you want to know that bit of information, and it is not specifically found in lots of other types of problems, right? Even people who have family history of rheumatoid arthritis can have positive rheumatoid factor. But it has a prognostic significance. කියන එක අපි කිව්වා නේද? මේක මම කියලා දුන්නා ඔයාලට. වැඩි වෙනකොට poor the prognosis, higher the extra-articular disease, right? And same with anti-CCP. But it is much higher sensitivity and much higher specificity for sure. Sensitivity should have very for rheumatoid arthritis diagnosis. Hari. So what are the questions? So rheumatoid factor, yes, in rheumatoid arthritis, ESR, CRP both are high, right? Compared to SLE where we say, okay, ESR is high, but the CRP is normal in a flare of SLE. Right. Okay. True or false? Discard the management of rheumatoid arthritis. So the next question number 6 is now focusing on the management of rheumatoid arthritis. Then මේක තමයි මම මේක ඔයගොල්ලන්ට කලින් discuss කරලා තියෙනවා නම් this is the flow chart for managing rheumatoid arthritis, right? We'll come back to this as we go through this MCQ. Right. Now the basic principle about rheumatoid arthritis management is you have to start everybody with rheumatoid arthritis on DMARD at the point of diagnosis. That is very, very important. So at the point of diagnosis, you need to start disease-modifying drugs. Very important. Palavani statement take a boru, right? DMARD therapy or patient radio joint erosion, that's absolute nonsense. Every patient with rheumatoid arthritis, at the time of diagnosis, DMARDs have to start. And methotrexate is the first-line drug. Clearly, methotrexate is the first-line drug. Methotrexate is a very sort of relatively safe drug, but there are some complications that you need to worry about, right? One is it can cause liver function derangement, right? So transient transaminase elevation. Another issue is it can cause lung problems, right? It can cause a subacute pneumonitis, and also it can cause leukopenia or pancytopenia. Right, so that's why you monitor them very carefully. Right, so methotrexate is the first line drug. හැබැයි මම කිව්ව මෙන්න මෙහෙම කතන්දරයක් DMARDs, the problem with DMARDs is they take time to work. They take time to kick in. And they at least take about 4 weeks to start working, at least. So for that period of time, until your drug starts kicking in and gets working, we will give a bridging course of steroids, right? To bridge the effect, right? We will give some steroids to bridge the effect. එතකොට මෙතෙන්දී DMARDs associated disease remission within 3 weeks of එක බොරු කතාවක්. This is wrong. So they take at least 4 weeks to start working also, right? So you'll never get remission within 3 weeks. More realistic is about 3 months, right? So disease remission, 3 months. You watch up to about 6 months, right? So you start the methotrexate and watch for about 6 months to, with a 4 weeks the treatment effect starts and it will go into remission if you're lucky in about 3 months, right? Usually. So until that period, we give a sort of bridging course of steroids, but remember, we have to keep the steroid course as short as possible, right? Now, alternate drugs to methotrexate in the first line would be something like leflunomide or sulfasalazine. Now, even though I've given HCQ here as a MCQ statement, and that is true, HCQ is not very useful in rheumatoid arthritis. It doesn't work very well. අපි දෙනවා තමයි, but it doesn't work very well as a DMARD in rheumatoid arthritis. Remember that. Right. This last MCQ එක කපා ගන්න is too much for you. ඒක උගලන්ට සැර වැඩි. Leflunomide. Remember, leflunomide can cause fertility issues, and also it can cause sperm and ovum function වල ප්‍රශ්න එන්න පුළුවන්, but ඔය වගේ fine details ඔයගොල්ලෝගෙන් අහන්න නැහැ ඒක කපා ගන්න. Sorry, don't worry about that one. Right, so essentially what you do is you start off with methotrexate and also use, if that patient does not tolerate that, you can use leflunomide or sulfasalazine. Right. Right. මෙතන මම සමහර ඒවල side effects ටිකක් දීලා තියෙනවා ඔයගොල්ලන්ට. Right. අර MCQ උත්තරේ ඕන නම් මෙතන තියෙනවා, but it is a bit too much for you කියලා මට පස්සේ හිතුණා. Right. This is for your reference. Now, before we go to the next one, I just want to tell you that so what happens if your methotrexate does not work? So you watch for about 6 months for it to work. If it works, fine, well and good. you can maybe try to reduce the dose a little bit and give a maintenance dose after that. But if it does not work, this is a bit important. මේකත් MCQ එක අහන්න පුළුවන් දෙයක්. If it does not work, there are two lines of management. One, if there are poor prognostic features. දැන් මොනවද අපි කිව්වේ? If your rheumatoid factor anti-CCP is high, that is a poor prognostic factor. If the disease activity is very high, disease activity එක මන්න indexes තියෙනවා. මම ඒවා ටික පැත්තෙන් ලියන්නම්. One is called C-die. Another one, there is one called S-die, and the other one is called DAS28. So if they are very high disease activity on these markers, on these scoring systems like C-die, S-die, DAS28, over a ගොඩක් වැඩි නම්, then again you will sort of, that is a poor prognostic factor, right? And of course, if they have joint damage, these are all poor prognostic factors. So methylized within. If they are poor prognostic factors, you will have to add in a biologic, right? At the second phase. Then අලුත් drug එකක් තියෙනවා JAK inhibitors කියලා tofacitinib. ඔක සමහරලාට MCQ එක අහන්න පුළුවන් එකක්. Tofacitinib. Tofacitinib. That's a JAK2 inhibitor which can also be used instead of a biologic. Because the biologics are injections and tofacitinib is oral, so it's a bit better to use, easier to use. Right. So at the second level, if the patient has poor prognostic features, then you would try a biologic or a JAK inhibitor. එහෙම නැත්නම් ඉතින් තව DMARDs එකතු කර කර යනවා. Right. Okay. Any questions about rheumatoid arthritis or any of those MCQs? Okay, right. Now the next thing we do is we go into spondyloarthritis, right? And of the spondyloarthritis group, this ankylosing spondylitis is the important one, or the sort of prototype disorder, right? Now remember, spondyloarthritis, there are special features of spondyloarthritis, and we will discuss them in this MCQ. But essentially, the special features are, they are common in males. So most of these rheumatological conditions are common in females, but spondyloarthritis is common in males. And remember, they are associated with HLA-B27. HLA-B27 positive product. So question number, going to question number 7. So pancytopenia methotrexate, yes, so it causes a folate deficiency. That is the main reason for pancytopenia, and you know that we need folate for cell proliferation. If we were given hyaluronic acid, hyaluronic acid, chondroitin sulfate, people use a lot in osteoarthritis, but there is no evidence that any of this has any benefit, right? So if you ask, they have a place scale, no, they don't have any proven benefit in trials. They never over there, right? So ankylosing spondylitis is more common in females, males like common. Now in ankylosing spondylitis, being the sort of prototypic spondyloarthritis, there you get a predominantly axial skeletal involvement, axial joint involvement, spine, and also sacroiliac joints are predominantly involved. Also in these spondyloarthritis, you can get lower limb joint involvement, peripheral, lower limb joint, large joint involvement as well. But most of them sort of have predilection for the axial spine. But some of them have peripheral monoarthritis or oligoarthritis. And that is in the lower limb, large joints. Right. Now, apart from this, articular involvement, patients with spondyloarthritis, especially ankylosing spondylitis, have soft tissue involvement, right? So plantar fasciitis is a presenting feature, it's true. They can also have this tendon inflammation, tendinitis, enthesitis වගේ features උත් තියෙන්න පුළුවන්. So tendinitis, enthesitis, plantar fasciitis. So So that's the sort of joint involvement, soft tissue involvement. As a predilection for the cervical spine, it usually involves the thoracic spine. Can involve the cervical spine also, but mainly thoracic spine, lumbar spine, then also the cervical spine with time. Right. Now, final thing to remember about the clinical manifestations of these are that there are extra-articular manifestations. And of that, here, of course, Siran, uveitis is very common, right? And also it can be associated with inflammatory bowel disease, right? And they can have lung involvement and cardiac involvement. The cardiac involvement is commonly aortic regurgitation. And the lung involvement is usually apical fibrosis, basal නෙවෙයි, apical lung fibrosis. This mainly causes the upper lobe fibrosis. So වගේ MCQ ඒවා පරිස්සමෙන් ගහන්න. හරි? Not basal, apical is predominant. So there are some extra-articular manifestations of the disease. Right. Any questions about this one? 7.
Sir, this in rheumatoid arthritis also, is it apical?
Rheumatoid arthritis, no. Rheumatoid arthritis is basal.
Right, okay.
Right. So here are some X-rays just showing you what it looks like, right? So as I told you, lower the thoracic and upper lumbar ඒ තමයි වැඩිපුර affect වෙන්නේ, but it can with time involve the whole spine. These words are not very important. Essentially, it causes calcification of the ligaments in your spine, right? And you get a bamboo spine. And you can see the pictures here of sort of very thickened interspinous ligaments and the other ligaments. Everything is very thick and calcified. Over the years, MRI has emerged as the main modality in diagnosing this spondyloarthritis. So X-ray වල පේන ගොඩාක් කලින් you will see these changes on MRI scan. And here is an example where you can see this sacroiliac joint involvement. Spine and sacroiliac joints involved. Okay. So, if somebody asks you what is a gold standard radiological modality for diagnosis, it is MRI scan, right? Not X-ray. X-ray වල පේන ගොඩාක් කලින් you see these changes on MRI scans. Right. And you treat them with physiotherapy. Physiotherapy, but actually physiotherapy is very important in the management of these conditions. NSAIDs have a place, as do TNF-alpha biologics, TNF-alpha blockers biologics. Infliximab is one of the commonly used drugs in this situation. Now, MCQ these other disease-modifying drugs like methotrexate, they don't have a place except when there is a large joint involvement or peripheral arthritis. Sulfasalazine, methotrexate sulfasalazine තමයි දෙන්නේ. But spine එකට sulfasalazine දීලා වැඩක් නැහැ. මේ ලෝකේ දෙයක් දීලා වැඩක් නැහැ. It's only NSAIDs and these biologics that work. But if there is peripheral joint involvement, කකුලේ knee එක වගේ ankle එක වගේ ගිහිලා තියෙනවා නම් then sulfasalazine might be beneficial. Right. Ankylosing spondylitis ගැන තව ටිකක් අහන්න. Schober's test is useful for the diagnosis. The Schober's test කියන්නේ මෙන්න මේක මේ පැත්තෙන් තියෙන එක. හරි. So Schober's test එක ඇත්තටම මේ MCQ එක ටිකක් controversial වෙන්නත් පුළුවන්. More than for the diagnosis, it sort of is a tool to monitor functional status as well as sort of treatment responsiveness. The diagnosis එකට අපි පාවිච්චි කරන්නේ නැහැ ඕක. Mainly අපි පාවිච්චි කරන්නේ Schober's test අර මෙතන පින්තූරේ පෙන්නලා තියෙන එක. හරි. අර නැවිලා බලන gap එක වැඩි වෙනවද අඩු වෙනවද කියන එක. That is mostly used for treatment monitoring and assessment of functional limitation. Right. අපි දැක්ක X-ray එකේ syndesmophyte formation කියලා එකක් කිව්වා. X-rays are more sensitive for බොරු කතාවක් MRI තමයි කරන්නේ. Chest expansion limit again because with time where the ribs join the vertebrae, those joints are also involved with time, and those ligaments are also involved and calcified. So with time, that chest expansion is also limited. Right. So මම අන්තිමට කිව්වා management එකට අපි පාවිච්චි කරන්නේ physiotherapy, NSAIDs and biologic DMARDs which specifically act on TNF alpha pathways. Sulfasalazine is useless for spinal involvement, right? Sulfasalazine, the place of sulfasalazine is when you have peripheral sort of monoarthritis වගේ තිබ්බොත් තමයි that is useful. Okay, so that is question number 8. Any questions about that? Right. Okay. Now this reactive arthritis is also in that group of spondyloarthritis, right? ඒ spondyloarthritis group එකේම තමයි ඒක තියෙන්නේ, but ඒකේ ගොඩක් වෙලාවට එන්නේ මේ spine එකට වැඩිය it causes mono oligoarthritis in the large joints. But it's still in that group because HLA B27 positive ඒගොල්ලෝ. It's sort of in that group of spondyloarthritis, but this is a peripheral, not an axial, right? Peripheral. So as the name suggests, this is a reaction to an organism infecting, right? And I have given you a list of organisms that can trigger off reactive arthritis. So, because this is included in the spondyloarthritis group, again, it is commoner in males, and it can occur following salmonella gastroenteritis. Plantar fasciitis also ඔක්කොම එකම වගේනේ. So plantar fasciitis known to occur මේක spine එකට වැඩිය mainly මේ large joint oligo or monoarthritis එකකට තමයි එන්නේ. Right. Now in reactive arthritis, which used to be called Reiter's syndrome, which have changed the name because Reiter was a Nazi, and they've changed a lot of those names that were named after Nazi doctors and scientists. Right. ඒකයි. There are a few special manifestations in පොඩ තප්පරයක් දෙන්න. Right. One of the unusual manifestations is this keratoderma blenneragicum. Right? Keratoderma blenneragicum you see in this reactive arthritis. Another thing is a special type of balanitis in the penis that occurs, and that is called circinate balanitis. Right? Circinate balanitis and keratoderma blenneragicum. Yeah, prognosis is poor in HLA B27 positive individuals කියන එක වැරදි. Right? එහෙම එකක් නැහැ. Most of them are HLA B27 positive. There is a subset who have HLA B27 negative, that is poor prognosis in those people. Sorry, ඒගොල්ලොන්ගේ poor prognosis, but this is wrong. Right. Any questions about question number 9? Your rheumatology, I think you are straightforward MCQs. These are all very straightforward. Yes, Sisura.
Sir, if plantar fasciitis, the statement is given, plantar fasciitis is common, is that true or false?
Common. That's difficult to say, right? You get a spectrum. I don't think they will ask you in that sense because it's spectrum of disease. They can get that as part of the disease process.
Right. Okay, sure.
Yeah. Right. Okay. Now we go into another connective tissue disorder where you can get an MCQ from, and that is Still's disease. Now, Still's disease we talk about a lot in the long case. Oh, Saman.
Sir, isn't Reiter's syndrome a type of reactive arthritis with uveitis?
No. Remember, Reiter's syndrome is now පාවිච්චි කරන්නේ නැහැ. So all of those are called reactive arthritis now. All of the types. UTI වලට නේව කොහොම these are all called reactive arthritis, and they are in that group of spondyloarthritis. Reiter syndrome කියන එක පාවිච්චි කරන්නේ නැහැ ඒ වචනේ because Reiter was I think a Nazi doctor or something, and he was in කළා.
Okay.
Right. Right. So Still's disease we have talked about when we did the PUO long case, and it is an important differential diagnosis of somebody with a PUO, right? And then the typical thing is this transient salmon pink maculopapular rash, which comes with the fever and then goes away. Now, the problem is that Still's disease, for the general principle is that there is a diagnostic criteria which is called Yamaguchi criteria. Right? Yamaguchi criteria. But an important prerequisite for this criteria is that you have to exclude other differential diagnoses. Right? You have to exclude other differential diagnoses. That is the whole idea of that criteria. In order to apply it, you have to exclude all the other differentials. And autoimmune diseases like SLE come into the differential, and in Still's disease, the ANA is not elevated, right? That is not a feature of Still's disease. What you get, however, is a very high fever and a transient maculopapular rash and sort of high neutrophils, high platelets, because platelets are also a marker of inflammation. So they get a neutrophil leukocytosis and thrombocytosis, right? Not thrombocytopenia. And with time, what happens when they have initially fever, sore throat, they have this fever, rash, and joint involvement. Some people have pericardial and pleuritic involvement, right? Very rarely carditis, myocarditis. So these are some of the manifestations, right? So cardiac involvement is, yes, myocarditis, myopericarditis is seen in Still's disease. Polyarticular involvement is also seen. So the Yamaguchi criteria apply karanna, there has to be, you have to exclude other diseases. There is no magic marker for Still's disease. Increased serum ferritin is useful to confirm the diagnosis. Take a baila katawak. Ferritin is high, there is no doubt about that, right? It is clearly high, but it is a non-specific test. The ferritin if there is inflammation anywhere, the ferritin will go up. So it is a non-specific investigation, right? Eking diagnosis confirm karanna beha. Eka boru katawa. That is wrong. Right. Any questions about that?
So is it a diagnosis of exclusion?
It is a diagnosis of exclusion. Yeah, that's a nice way of putting it. Yes. So lymphoma, autoimmune disease, exclude color. Finally, we can say, okay, this might be Still's color. We can label it, right? But it is essentially, yes, it is a diagnosis of exclusion. Yes.
So for peds, we learned that it has to be this like a quotidian fever or
we have stopped teaching you fever patterns because they are no longer valid. The quotidian fever, yes, that is a description that people use. But when you use paracetamol, you use antibiotics and various other drugs, NSAID, all of these fever patterns you rarely see in clinical practice anymore. So you are not going to wait until you see a quotidian fever to diagnose Still's disease. All right?
Right, got it. Thank you.
Right. Okay. Right. So the next MCQs are next few MCQs, I think up to 13 are on crystal arthropathies, gout. Now there are lots of crystal arthropathies, but for an undergraduate level, gout tamai uguru danaganna one. Now in gout, there is hyperuricemia and deposition of monosodium urate crystals in the joints. That is what happens. Here I have given you a list of causes of gout. Right? Some of the causes are due to reduced uric acid clearance. For example, in renal failure, there is reduced reduction of the uric acid clearance. Right? Or sometimes you can have increased production of uric acid. Right? And this is seen in these disorders with high cell turnover, like myeloproliferative or lymphoproliferative disorders, also with alcohol. So these are the causes, and the question number 11 is asking about the causes of gout. Right. Right. Now, the spectrum of gout can vary from the common thing, which is this first metatarsophalangeal joint involvement, right, which is the common manifestation, or it can cause this sort of disease on the right with sort of polyarticular involvement and tophi. Gouty tophi, all of these are gouty tophi. Right? සමහරට ඕක rheumatoid arthritis වගේම තමයි පේන්නේ, but you should be able to identify the gouty tophi when somebody comes to you. Right? Okay. Right. So that is what you see. True or false regarding gout? Acute attacks of gout have a predilection for the first metacarpophalangeal නෙවෙයි metatarsoophalangeal. Right? So that is the foot, right? First metatarsophalangeal joint is involved, right? Now, but remember, gout can involve any joint, as you have seen. It can involve, like a rheumatoid arthritis, it can involve a polyarticular gout, or it can cause a knee joint or ankle joint involvement. And when it does cause this knee joint, ankle joint involvement, it presents identical to maybe something like septic arthritis. ඒ වගේම present like septic arthritis, very acute, painful joint swelling එකක් එනවා. And if you aspirate that joint, you will see a neutrophil predominance. හැබැයි ඕක septic arthritis තරම් ලොකු neutrophil infiltrate එකක් එන්නේ නැහැ, but you will see a neutrophil predominance in a gout. Right. So how do we diagnose it? So the differential is septic arthritis. You aspirate the joint, you will see neutrophils, right? And also, Lankavet, it is metatarsophalangeal tamai. I don't know whether any studies showing that it is not the metatarsophalangeal joint, but knee එක ඕනතරක් involved වෙලා එන්න පුළුවන්. So we are talking about the diagnosis. So presentation, acute gout, aspirate, you see a neutrophil infiltrate, and then you send off the joint fluid for crystals. Right? And this is the appearance. So you can see the neutrophils in the joint fluid there. And these are called negatively biofringent needle-like crystals. Right? So the description is negatively biofringent needle-like crystals. Whereas there is another crystal arthropathy which is called pseudogout or calcium pyrophosphate disease. ඒකේ එන්නේ positively biofringent rhomboid crystals. ඒක මම පින්තූර දෙක දෙපැත්තෙන් දාලා තියෙනවා for you to remember, right? So this rhomboid positive biofringent is seen in pseudogout or calcium pyrophosphate disease. So that is how you diagnose gout, right? Remember, the uric acid level can be normal or low in a acute flare, right? In between a flare, this will be sort of in between a flare, and this can be normal. It's high, but during a flare, that will be samarlata low. So you can't go by the uric acid levels. Negative biofringent crystals, positive biofringent, negative biofringent. Right. Now, radiologically, especially in those sort of polyarticular gouts, you see these sort of punched out lesions. Right? Punched out lesions. Punch එකෙන් pill හැදුවා වගේ punched out lesions. Right. Right. Sorry. Right. So how do you treat gout? Acute episode, you need to manage NSAIDs පාවිච්චි කරනවා, steroids පාවිච්චි කරනවා, colchicine පාවිච්චි කරනවා. Right? That is the acute episode management. And in some people, you need to give them long-term therapy with uric acid lowering medication. Long-term therapy. Right? ඒවට indications සමහර ඒවා අපි මෙතන දීලා තියෙනවා. Especially people with renal impairment. Right? අපි patients with tophi, right? And certain side effects of acute therapy. There is also, you can base it on the uric acid level. Samahara guidelines. So for those people, you give chronic hyperuricemic therapy, and that is with allopurinol. හරි allopurinol. ඔය තව තියෙනවා febuxostat කියලා එකක්. ඒක වැඩි ලංකාවේ පාවිච්චි කරන්නේ නැහැ. Febuxostat, right? Allopurinol, febuxostat. හරි. මේකට අපි ආයි ගියොත් එහෙම allopurinol is treated used in acute gout කියන එක බොරු කතාවක්. It is used in preventing recurrent attacks of gout. So it is mostly used for the chronic management. ඒකට තමයි අපි mainly පාවිච්චි කරන්නේ. Right. Any questions about this one? Right. Diagnosis එකයි management එකයි කතා කරා. Question 11. Right. පොඩ ඉන්න. Right. Question 11, lead, sorry. Yes. Hari, ek hari. Okay. Right. Now, this question number 13 is on the most severe spectrum of gout, which is chronic tophaceous gout. So, ඒක තමයි මෙන්න මේ වගේ පින්තූරෙමේ අත්වල, right? Polyarticular involvement, tophi, right? And also punched out lesions like this. That is the most severe form of gout. So gouty tophi අත්වල එන්න පුළුවන් මේ පිනේ එකේ කනේ එන එක is very common. Right? You can get chronic tophaceous gout in renal disease. That is the most severe form of the disease. It causes punched out bone cysts. And in chronic tophaceous gout, you need to give some sort of uric acid lowering therapy, right? Because it has a very poor prognosis. So allopurinol පාවිච්චි කරනවා. හරි. මෙන්න මේක මෙතෙන්ට අදාළ දෙයක් නෙවෙයි. ඒක වැරදි. There are certain ඒ කියන්නේ මේක මෙතෙන්ට අදාළ ගන්න මේක කලින් ප්‍රශ්නේ තියෙන්න ඕන එකක්. But remember that you don't give a single attack of gout. There will be special indications. හැමදාම මෙතෙන්ට ගත්තත් ඉතින් කමන්නේ ඔකට කියනවා chronic. Yeah, මේක මෙතෙන්ට අදාළ නැහැ මේ statement එක. ඒක කපා ගන්න. Right. Any questions about gout ළමයි? ප්‍රශ්න මොනවද තියෙනවද? Okay, right. Right. So the last few questions are on SLEs, right? Now, SLE is a familiar disorder to you. We've talked about this in a long case sort of context as well, right? And these are some important MCQ points that you need to remember. Common in females, obviously, you know that. And remember, there is an integral link with the complement pathway in the pathogenesis of SLE. And if the hyperuricemic therapy පටන් ගන්නේ මේ indications තියෙනවා විතරයි. So if you have renal impairment and gout, chronic tophaceous gout, and if there are repeated episodes where you're getting side effects with therapy, ඒ වගේ වෙලාවට තමයි පටන් ගන්න. Okay, so for SLE, these are important. There are certain triggers of SLE that we have now recognized, and these are some things that we can ask in the MCQs. And also there are certain forms of drug-induced lupus, like secondary to procainamide, hydralazine, right? Chamatkatin, so if somebody was a flare while on allopurinol, should it be stopped කියන එක? That is a bit of a difficult thing. හරිද? ඒක හැම වෙලේම නවත්තන්නේ නැහැ. Okay, so question number 14 is, so මේවා ටික හරි. Complement pathway, yes. hydralazine, procainamide are causes of drug-induced lupus. And we've already discussed this story earlier that, and long case එකත් මම මේක කතා කරා. In an acute flare of lupus, right, ESR is high, but CRP is normal, except, right, when there is serosal involvement. So if you get SLE with serosal involvement, then you can get both the ESR and the CRP going up, right? But in all other situations, if there is a pure flare of SLE, it is just the ESR that is elevated. Another important marker of active disease in SLE is the complement level, right? So classically, we will describe that in a flare of SLE, their complement levels will go down, right? So their C3 and C4 will be low, right? So this is just a little bit about risk factors or triggering factors for SLE, and also about some of the investigation findings in a flare of SLE. Another important thing to keep in mind is, in a flare, they get leukopenia with lymphopenia. So their white count is low and their lymphocyte count is low. So leukopenia with lymphopenia. Right. Now this I've shown you during the long case. There is a new criteria for, it's a classification criteria which can be used for the diagnosis as well. Classification criteria ගොඩක් පාවිච්චි කරන්නේ for clinical trial purposes, but we use this in clinical practice as well. And one of the important prerequisites now is a positive ENA at a titer of 1 in 80, more than or equal to 1 in 80. And then following that, there are several domains that you go through. So in those domains, there are immunological criteria, right? Low complement levels, and also antiphospholipid antibodies. Immunological criteria, right? You have antiphospholipid antibody, presence of antiphospholipid antibodies, low complement levels. We just talked about that. And there are 2 SLE specific antibodies, right? So anti-dsDNA is one of them, and anti-Smith, anti-SM කියන එක එතන නෙවෙයි, Smith කියලාම ලියනවා. anti-SM කියලා ඔයගොල්ලෝ හිතන්න පුළුවන් smooth muscle antibody කියලා. ඒක වැරදි. So this is anti-Smith කියලා හදාගෙන, that is true, right? So there are 2 SLE specific antibodies. One of them is anti-dsDNA antibody, and the other one is anti-Smith antibody, right? Exacerbations are known to occur in pregnancy is true. Now, in the treatment of SLE, it's all a spectrum of disease. SLE can sometimes cause dangerous, life-threatening manifestations like seizures, renal failure. But actually, in most people, it is a mild disease. The general treatment principle is anybody with SLE, however mild or severe the disease may be, right, you will give them hydroxychloroquine, right? 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 So hydroxychloroquine හරි. මේ තිස්සුර මේ මොකද්ද වෙලා තියෙන්නේ මේක?
The NICE guidelines for gout has what you mentioned, sir, but the British Society of Rheumatology says to start allopurinol in all patients after 1 attack. Yeah.
Interesting. There has to be something in deep into this. I will have a look at this and let you know.
Sure. Thank you.
මොකද මේක ඇත්තට මොකද evidence එක කියලා පොඩ්ඩක් කියවලා බලන්න ඕනේ. Now sometimes these buggers come up with these recommendations and then people are arguing about it till the cows come home. මොකද්ද මේක කියලා තියෙන හේතුව කියලා බලලා මම ඔයාලට කියන්න. Option of ULT should be explained and offered to all patients go to the part of the education. It's a bit of a vague statement. නේද? අමුතු statement එකක් ඒක. Right? But for all means and purposes, for your purposes, the thing I have taught you is correct, but I don't know what this thing is. Okay.
Right. Thank you.
Right. So HCQ is a drug that should be given to all patients with SLE, regardless of what state of disease they have. And there are lots of benefits of giving this. Especially the key benefit is that it sort of reduces the risk of relapses of the disease. That is one of the main benefits, right? Risk of relapses are lower. That is the first important thing to remember. Also, we have now realized that when you give hydroxychloroquine in the long term, right, it reduces the cumulative damage of the disease. So it reduces the risk of cumulative damage due to the disease, right? So these are the advantages of HCQ. So it reduces the relapse rate, plus it reduces the cumulative damage due to the disease. So all patients SLE are recommended to be commenced on HCQ ekahari. Right. Now, systemic steroids are indicated in all patients. Obviously, you don't give systemic steroids to everybody. Patients with skin disease, you don't give systemic steroids, right? So, or very mild forms of the disease, sometimes you don't give anything except for HCQ. So that is false. But of course, in patients with very severe life-threatening disease, organ problems, you do give them systemic steroids, IV, oral steroids, high doses. But remember that the main principle here is trying to keep the dose of steroids as low as possible, right? So the steroid it is a very good drug, but in SLE, a main principle of treatment is we are trying to get the steroid dose down and under control very quickly. Right? Right. Now, finally, in patients who have very severe organ manifestations, we use strong immunosuppression, like cyclophosphamide, MMF, drugs, and they are effective. So, MMF is effective to achieve remission in renal lupus is true. So is cyclophosphamide, right? Mainly renal lupus, right? Especially the more aggressive forms of renal lupus like class 3 and class 4. Right. Any questions? Right. So we've gone through sort of the triggers for SLE, gone through some of the important investigation findings for a SLE flare and some management, why HCQ is important, the role of steroids and all of that. Right. Now, vasculitis is under rheumatology, but it is not a common question that we ask you because it is a very complicated business. The only thing we might ask you is about one type of vasculitis called giant cell arteritis. Right. Now, in neurology also, I'm sure somebody would have taught you that giant cell arteritis, the common presentation is with this unilateral headache, right? Temporal, very unilateral headache, right? And it can also be associated with loss of vision, right? Loss of vision. ESR is elevated is true. So that is the right? Common story, right? Common story is you get very unilateral temporal type headache with a high ESR. That is a typical story, right? Giant cell macrocytic anemia එක හරි but ඒක නිකන් ඒක right. I would say මේක කපා ගන්නකො ඒක පොඩ්ඩක් අවුල්ලේ statement එක. ඒක වැඩක් නෑ. Right. Giant cell arteritis can be associated with another disorder called polymyalgia rheumatica, right? And that mainly involves it causes pain and stiffness of the proximal muscles. Distal muscles, never. So polymyalgia rheumatica is a disorder which predominantly causes a pain and stiffness of your proximal musculature. Right. Now, how do you diagnose this condition? How we diagnose this condition? Those days, we used to do a temporal artery biopsy as the first gold standard test. Temporal artery biopsy. The problem with doing that blindly is that in giant cell arteritis, the vessel is not involved continuously. So it's sort of a patchy involvement, 10 involvement. If you biopsy a place where the vessel is normal, you might get a normal result. So currently what we recommend is, first what we do is ultrasound Doppler of the temporal vessels, and people are trained to do that. You have to have some special training to do that. So currently what we do is this special test where we do a Doppler of the temporal vessels and then do a biopsy also. But you can identify the disease, where the disease is in the temporal artery Doppler, and then biopsy a relevant area without blindly going in. So nowadays, in addition to the temporal artery biopsy, which you might ultimately do, you also do a Doppler of the temporal artery. And it is not, you can't exclude it by a normal temporal artery biopsy because the disease can be patchy. Temporal artery involved in there, it can be a patchy disease. Right. The thing about giant cell arteritis, it has a beautiful dramatic response to steroids. Right. And somehow that steroid navatta gannat beha the moment you wean it off, it comes back. So steroids have a big role to play in giant cell arteritis. Other drugs denama, but steroids, it has a very, very quick response. And somehow that a diagnosis for it we use. Headache steroid headache the temporal headache. You give steroids, it just disappears immediately, almost next day when you got nothing, right? So it has a dramatic response to steroids, it's true. So that is the only type of vasculitis that we will give you because the rest are very complicated and difficult for undergraduates. Hari, any questions? Right, okay. Right, now the last true-false question is on osteoporosis. Right, osteoporosis. We have given you a big table of all the causes of osteoporosis. Anything can cause osteoporosis. So, by nature, true gahana dannattam. If somebody asks you what are the following causes of osteoporosis, when I have given you the definition there as well. Right. So let's do question number 17. Right. Hari, better definition එක තියෙනවා. Okay. Right. So low BMI is a risk factor is true. DEXA scan is a special type of scan that we use in the diagnosis of osteoporosis. Right. Okay. And this is what it looks like. And there are various cutoffs for the bone mineral density. And it gives you something called a T-score. Right. Now, the management of osteoporosis is very difficult. The only thing you need to know at the undergraduate level is, before you treat osteoporosis, the main thing is that you have to estimate the fracture risk. Right? Usually this is done for 5 years. Right? So you estimate the fracture risk for 5 years. And the treatment is depending on that risk. Treatment, whether you start treatment or not, depends on that risk. Right? So how do we calculate this risk, right? The risk of a fracture, somebody with diagnosed osteoporosis, a risk of a fracture in the next 5 years. How do you calculate that? That is using something called the FRAX score. And there is a country validated FRAX score. The internet it will take you to a site and you can select Sri Lanka. And when you input the points into that, it will give you a score, risk score. Remember, to calculate the FRAX score, you don't essentially need the DEXA findings. එක දාන්නත් පුළුවන්, නොදා ඉන්නත් පුළුවන්. නොදා ඉන්නත් score එකක් එනවා, දැම්මත් score එකක් එනවා, right? So even without the bone mineral density assessment, DEXA scan value, you can still calculate the FRAX score. And the treatment depends on this FRAX score. So මේක හරිම complicated. මේ පේනවනේ මේක නිකන් අර මොකාගේ දෙක වගේ. Don't worry about this. Nobody is going to ask you about it. But the risk is sort of calculated on the FRAX score. 5 years, 10 years would calculate කරනවා. Some guidelines say calculate the 10 years score, 5 years score එකත් calculate කරන්න පුළුවන්. And then based on the risk, you go on the treatment. Low risk නම් සමහරට you don't give anything at all. Right. The treatment is commonly with bisphosphonates, right? Also, there are other drugs that we use called denosumab, teriparatide, right? And various monoclonal antibodies. Right? Romosumab, that is a monoclonal antibody. It targets osteoclasts, right? So that's a very sort of advanced topic. Nobody's going to ask you too much about, right? But osteoporosis, the treatment decision is made based on the FRAX score. And you use bisphosphonates for the treatment. Commonly, bisphosphonates. Bisphosphonates were dangerous side effects. Ekak tamai this one, osteonecrosis of the jaw. Right? That is a dangerous side effect of bisphosphonates. Another problem is when you use bisphosphonates for a long time, it can also cause fractures. The reason is that it targets the osteoclast, and the osteoclast is needed for bone turnover, healthy bone turnover. So if you suppress it for a long time, it can also cause trouble, right? So ඒක පොඩ්ඩක් මතක තියාගන්න, right? Atypical fractures කියලා වට කියනවා. Atypical, usually the femur, right? Now, and also you know that bisphosphonates can cause esophageogastric erosions. Right. Now, over the years, steroid-induced osteoporosis has become a big problem, right? Over the years. And මෙතන මම පොඩි slide එකක් දීලා තියෙනවා ඔයගොල්ලන්ට ඒක ගැන. Currently, the recommendation is if you are giving a patient prednisolone more than 7.5 milligram or equivalent, then dexamethasone equivalent එකක් හදන්න පුළුවන්. For more than 3 months, you have to give them bone protection prophylaxis. Osteoporosis නොතිබුණත් අපි bone protection දෙන්න ඕනේ ඒගොල්ලන්ට. So 7.5 milligrams for more than 3 months. දැන් සමහරට SLE patients that osteoporosis නැහැ. But we are giving them steroids more than that threshold dose of 7.5 milligrams for more than 3 months. So you need to give them prophylactic bisphosphonates. That is something you need to remember. Hari, any questions? Customer hari තියෙනවද ඒව ගැන? හැබැයි remember, any dose of steroids can cause osteoporosis. ඒතර මේ පළේ පස්වෙනි එක negligible නෑ. හැම dose එකකම you can get osteoporosis. But currently the recommendation is only to use it if it's 7.5 milligrams or more for more than 3 months.
Sir, it can inhale steroids also, like for asthma?
Yes. Yes. Less, of course, the risk is less, but yes, there is a possibility.
Right. Okay. Thank you.
Now then we go to the best response MCQs. But I don't need to discuss all these in detail because we have gone through all these concepts in the previous questions. නේද? ඒතර මේකට උත්තරය මොකක්ද? මොකද්ද මේකට උත්තරේ? දැන් මේ කිව්වනේ. Yeah, go. Methotrexate. Yes. Right. So that is the first line drug.
Methotrexate.
Yeah. Okay, good. මේකට මොකක්ද උත්තරේ? So this again a patient with rheumatoid arthritis worsening breathlessness. Currently on NSAIDs and paracetamol, blah, blah, blah. There is pallor and the hemoglobin is low and there seems to be a platelet low and it's a pancytopenia with a low reticulocyte count. So what does that mean? That there is a bone marrow production problem. When the reticulocyte, this is actually the index, is low, that means there's a bone marrow production issue. So what is the treatment? What is the cause of this bone marrow production issue most likely, Lamai, causing the pancytopenia?
Methotrexate?
Yes, methotrexate. Yeah, that is absolutely right. Methotrexate, we can get folate deficiency as we discussed earlier, and that causes a pancytopenia. The red cell production is reduced in the bone marrow, and of course the other cells as well. Good. Make a mokadda. So again, a rheumatoid arthritis patient, desaturating, relatively acute onset illness. And there are infiltrates, but no evidence of infection. Cultures, blood cultures, Felty syndrome, you get a mainly a leukopenia with a splenomegaly. So that is a different thing. Yeah. Now, chronic disease pancytopenia in you can get a little bit of a low hemoglobin because of bone marrow suppression, but it's just the anemia, not the pancytopenia. Okay, so again the answer is methotrexate. Prashna 3ට උත්තරේ methotrexate. Here this is a subacute pneumonitis due to methotrexate, which is a complication of methotrexate. Side effect of methotrexate. Hari. මේ මොකද්ද මේ? Neck pain. Right, there is some evidence of narrowing of the joint space, partial collapse of C4, high ESR නේද? මොකද්ද වෙලා තියෙන්නේ patient ගේ? මොකද්ද උත්තරේ මෙතන? මේක මේ මම උත්තරේ දීලා තියෙනවා. Sorry, so this is TB, right? TB of the cervical spine. Right? So joint space narrowing, sort of collapse of vertebral bodies, is common in. Okay. Right. So this is monoarthritis of right ankle, heart failure තියෙනවලු fusamide පටන් ගත්තලු මොකක්ද උත්තරේ මෙතන? Easy one.
Gout.
Gout. Good.
Gout.
Hari. මේ මොකද්ද මෙතන වෙලා තියෙන්නේ? අනේ මේකේ reference ranges දීලා නෑ නේද? Sorry. මේක මෙතෙන්ට අදාළත් නෑ හැබැයි නේද?
Question 4 වල
question 4 වල
question 4 වල alkaline phosphatase වැඩි නේද? ඒක අර
වැඩි. ඒක vertebral bodies collapse.
value එක වැඩිද normal
වැඩි මේක වැඩි. myeloma වල joint space narrowing එකක් ඉන්නේ. Also the alkaline phosphatase is the calcium would be much higher than this if it's myeloma. Alkaline phosphatase has value if there's a fracture in myeloma, but calcium would be much higher than this if it's a myeloma or a malignancy. හරි මේක මෙතෙන්ට අදාළ නෑ ඒක අමතක කරලා දාන්න. මේක මොකද්ද මේ? rheumatoid arthritis බෙල්ල මොකක් හරි වෙලා නේද? දැන් මොකද වෙලා තියෙන්නේ මෙතන? මේකත් අපි කතා කරා. උත්තරේ. No. Yes. Possibly usually thoracolumbar, but we have seen plenty of it in the cervical spine. Right? So this is atlantoaxial subluxation. Ned. Right. Question number 22. Now there is a photosensitive rash, cheeks rash. Positive today. What will you do now? So just a skin rash, nothing else, but this is a diagnosis of SLE. So I told you all patients with SLE, unless there are MCQ complication, contraindication, but essentially we need to start the patient on hydroxychloroquine. Right? That is, of course, the thing you have to do. Right. So we want to discuss the concepts, so yeah, these are easy ones. Right. හරි මේ ප්‍රශ්නේ මම ෆ්‍රැක්ස්කෝ එක දීලා නැහැ ඒක වැදගත් මේකට ඒ නිසා I'm just going to ignore this question. If they give you a question on osteoporosis, they will give you the Fraxco and also tell that the 10-year fracture risk is high කියලා or whatever. මොකක් හරි එකක් එතන interpretation එකක් එක්ක දෙන්න ඕනේ, that's important to decide treatment. හරි? So there is a bit of a deficiency in this question. You need the Fraxco for this. Yeah, to make a good decision on what to do. Common osteoporosis and MCQ is a very complicated area. High mokad calcium phosphate will mukut penne osteoporosis well. Such high mokad high own na kilabang vedakne. Raloxifene is again used in osteoporosis management. I own name make a mukati and make calcium phosphate is sort of marginal, right? Yes, most of the time we some raloxifene postmenopausal at pavichi karana. But they have to saravedi ekame right, okay. Ekat hari hena. Rheumatology. හතරේ rheumatoid arthritis කරන්න පුළුවන්. දැන් මේ rheumatoid arthritis partial or vertebral collapse එකක් එන්නේ නැහැ හිරන්නේ. ඒක that is very typical of TB. The joint space narrowing and the vertebral collapse is very typical of TB, right? You don't see that in rheumatoid arthritis. වලට කංගර vertebra එක පනින එක විතරයි වෙන්නේ. Subluxation. හරි. Okay. ප්‍රශ්න මොනවද තියෙනවද? හරි චමල්. ඒක හෙට infectious disease මේ ප්‍රශ්න ටික දැම්මේ නෑ නේද? දැම්මද? infectious disease මේ ප්‍රශ්න ටික දැම්මේ නෑ නේද?
නෑ ඒක තාල් තිබුණේ
නෑ නේද? හරි මම ඒක දැන් දාන්න. ඒක ඇත්තේ මම හිතන්නේ ප්‍රසන්ටේෂන් එකක් අස්සේ හරි මොකක් හරි තමයි මම වෙනම පේපර් එකක් හදන්නේ නෑ. හරි මම ඒක හොයලා දාන්නම් කොහොමද තියෙන්න ඕනේ හොයාගන්න. මේ තියෙන්නේ. ඔව් හරි. ඒක මේ ප්‍රසන්ටේෂන් එක ඇතුළේම තමයි තියෙන්නේ. ඒක කරගෙන යන්න. හරි? right. Okay. So මම ඉන්ෆෙක්ෂන් ඔක්කොම කරන්නේ අර මිස් වෙච්ච ඉන්ෆෙක්ෂන් ටික තමයි කරන්නේ. හරි? right. Okay. Right. I'll see you tomorrow. හෙට වෙලාව දැන් අද පටන් ගත්තේ කීයද?
Okay. Thank you very much. අද 8යි කාල මෙහි
8ට පටන් ගමු. 8ට. හෙට. Right.
Thank
So
you, sir.
Sajid, osteoporosis
Hari.
වලට calcium supplementation දෙන්න ඕනේ because if there is underlying calcium deficiency or vitamin E deficiency, the bisphosphonates won't work. That is why you give it, but not because the calcium. If you have osteoporosis patient with low calcium, there is osteomalacia also. Osteoporosis itself doesn't cause low calcium or any change in the phosphate. Hi. Okay, right. I'll see you tomorrow then.